Welcome everybody to this Otometrics webinar about tinnitus assessment. This webinar is the first webinar in a series. Sounds like we have some. It's the first webinar in a series of 3 webinars from Otometrics, and the full list of all webinars can be found on the Otometrics website. My name is Mette Berntsen. I am from Otometrics Marketing, and I will be the moderator of today's session. I'm here with Clement Sanchez. He's audiologist and product manager at Otometrics, and he will be the person presenting this webinar today. Before we start, I'll just give you a little bit of information about how we will run this session. First of all of you have been muted, and that's basically to reduce whatever background noise there might be. But it is, of course, still possible for you to ask questions during the session, and you do that by using the question box in your webinar menu. I will then collect all questions that come in during the session, and at the end of Clement's presentation, we will go through as many of your questions as possible. And in case there will be questions we don't get to, we will make sure to reply or send you an email with the reply after the webinar. If you experience any technical problems or need any support, please write me directly. You will find my name also in your webinar menu under Mette Berntsen. There might be a short delay in slides from time to time, and don't worry about that. I mean, the system would catch up automatically as we go. And now I will hand over to Clement.
Hi everybody, thank you for joining the webinar, our first one. This one is about tinnitus assessment, so it's very exciting. And well, actually, as Mette said, my name is Clement Sanchez. I'm product manager for hearing assessment, which include actually audiometers and emittance devices. The module and the application I will mention today is about the latest one we have included in our Astera 2 audiometer, which is a clinical audiometer. And I'm also an audiologist, and I'm very excited to talk about tinnitus because in my previous practice, I used to meet actually tinnitus patients, and I used to make some kind of assessment with the equipment I had at this period of time, and it was not easy at all. Actually, it was possible, but it was not comfortable because nothing was integrated and nothing was very dedicated to tinnitus at this period of time. So that's why I'm very excited in Otometrics to work on such area and to present today something concrete for professionals who meet tinnitus patients. So I will start this presentation with a brief introduction, recalling the challenges of professionals working with tinnitus patients or people complaining about tinnitus. And then I will review the different reasons for conducting this tinnitus evaluation. And then we will talk about the psychoacoustical measurements and the questionnaires included in this module in details. And finally, a brief conclusion, and we will have a session of questions and answers. So I just would like to recall the challenges about the tinnitus patients. We know that patients with tinnitus symptoms present unique challenges for tinnitus, for audiologists, sorry, but just remember that tinnitus symptoms vary widely, and it's not always easy to interpret the severity of the tinnitus. So while there are methods for reducing the symptoms of tinnitus, there is in fact no cure-all for tinnitus today. So this can make it difficult to know where to begin when a tinnitus patient walks into the audiologist clinic. So tinnitus is a subjective phenomenon, as you probably know, but it makes actually difficult to evaluate objectively, with it being measured, quantified and described only based on the responses of patients. So actually the sounds associated with most cases of tinnitus have been described of being analogous to hissing, clicking, rigging, crickets, rhythm, a lot of different words expressed by the patient himself. But what to do with these words, with this interpretation of the sound? So that's actually the difficulty in our world. So an audiologist meeting a patient complaining of tinnitus needs to identify and quantify the subjective symptom. So this is necessary both to establish the clinical type of tinnitus and to recommend the correct instrumentation to manage the tinnitus. And according to Richard Tyler, the quantification of a symptom is fundamental to understanding its mechanisms and treatments. And if we cannot measure it, we cannot study it. So assessment and dialogue play a crucial role in managing tinnitus. So with an assessment, the person with tinnitus can see the condition illustrated and quantified on an audiogram. So let's start with a review of the different reasons for conducting a tinnitus evaluation. First of all, description of the tinnitus by the patient himself, meaning the quality of the tinnitus we mentioned before, ringing, clicking, hissing, may be difficult for the professional to start on a valuable basis for communication. So the evaluation gives a more objective picture of the tinnitus with level, frequency, maskability, etc. And we will go into detail afterwards. Then the evaluation will show the patient that the sound is in his ear is real. It also gives the professional to show to the family an estimate of the sound by simulation. In order to track changes or evolution during the follow-up visits, the evaluation provides reference points. But also it helps the professional to set the level and the frequency range of the sound therapy, and for the otologist to determine the site of origin of the tinnitus. But also, two patients may indicate that their tinnitus is of a ringing quality, but the maskability may be present for one of them and not for the other, resulting in clear subcategories. Evaluation will help the professional to determine if the sound therapy can be helpful for the patient or if a specific sound stimulation has a positive effect or not. And finally, for legal reasons, some points may need to be validated, such as the presence of the tinnitus, the degree of impairment, disability, and/or handicap. Okay, so now after reviewing the different reasons for conducting this evaluation, it's time now to take a look actually on the psychoacoustical measurements and questionnaires which are included in the module of the Matsen-Astera. Any professional should actually know a few points before starting measuring the different components. And these few points, it starts with the equipment. What kind of equipment do you need? The first point is actually to perform the tinnitus evaluation, the audiologist needs a 2-channel audiometer with pure tone, narrowband noise, and broadband noise stimuli. This audiometer should also allow stimulating both unilaterally and bilaterally in high frequencies up to 20 kHz, as well as the capabilities for 1 Hz resolution, 1 dB step size, and also providing the octave confusion test called OCT. And I will talk about this afterwards. Regarding the measurement method, there are many different measurement methods existing, but today the most popular is the method of paired comparison, where the patient is asked to choose the closest tone among 2 different ones. After choosing one, the second trial is presenting using the selected tone and a higher one until the patient confirms a level or a frequency. So this 2 alternative forced choice method was also suggested as the most reliable method for tinnitus measurement. And what about the test ear? That's also a question the professional need to give an answer, because the test ear selected can have an influence on the results. The pitch, for example, may vary according to which ear received the tones. If the stimulation is ipsilateral, the tinnitus may change in response to the presentation. However, inaccurate results may be obtained when simulating the contralateral ear. And finally, binaural presentation can be problematic for these reasons and because the patient likely hears differently from each ear. However, there is a consensus among professionals to recommend the monaural, ipsilateral testing with the audiologist noting the test ear. And finally, the stimulation. What kind of stimulation can we use when we do the evaluation? The recommendations are to use a pure tone, but narrowband noise is also used despite the potential problems of using this as a stimuli. An alternative solution is to use the fresh noise, which is the frequency-specific hearing assessment noise described by Dillon in 1984, and this noise is a narrowband noise signal that has been designed with extremely steep filter slopes. The continuous stimulation is preferred instead of the pulsed one, as the latter seems to be more difficult for the patient. And finally, the time presentation should be around 500 milliseconds with 5 seconds intervals. Okay, so now let's take a look at the different components and questionnaires included in the module. And you can see on the slide the screenshot of the module we are talking about. On the right part of the screen, you have what we call the psychoacoustical components, which are all gathered on a very nice table. Nice because it's very open, very flexible for the users to use. You can use on the right ear column, the left, the binaural, and change the date to record and track the results. On the left part of the screen, you have an easy access to the different questionnaires included in this module today. Let's start with the psychoacoustical components. Here you have a better view of the table I've mentioned before, where you can see the different components on the left column. So it starts with the pitch matching. Is usually the first measurements we do, and it's usually expressed in hertz. Then the professional will be invited to perform a loudness matching, which is usually compared to the level of the tinnitus. Then it will be the masking, which is usually considered as very, very important when it's about tinnitus patient. And then you can research actually the MML, the minimum masking level, which will be used to the next measurement, which is the residual inhibition expressed in seconds or minutes. And I will explain what is the residual inhibition afterwards. So let's start with the pitch matching. So the pitch is actually the psychoacoustic outcome that corresponds closest to the physical dimension of frequency, and that's why it's expressed in hertz. And it's the most common measurement that attempts to quantify tinnitus for frequency. Pitch matching can be used as the reference point for discussion and for selection and fitting of acoustical instrumentation. So when pitch matching is performed, it should be supplemented with an octave confusion test. I've mentioned that before. It's the OCT. And the octave confusion can occur, it's a phenomenon that can occur when a patient identifies a specific frequency as the pitch match of his tinnitus, but with further testing, the tinnitus is actually identified at 1 octave above the original pitch match frequency. So generally, the pitch match doesn't fall into the standard audiometric frequencies. So using smaller increments may be needed. So that's why I've mentioned the resolution of 1 hertz available in audiometers. It's very, very important if you want to go into high resolution and better accuracy. So it is also important to measure a standard audiometric threshold at this frequency if it's not in the original standard frequency used during the previous audiometry. Loudness matching. So once again, two alternative forced choice methods starting slightly below the absolute threshold is recommended for comparing the loudness of a presented stimulus to the tinnitus loudness. This method minimizes the effect of residual inhibition we will talk after. Care should be exercised while working with loudness matching. I said that it's about the level, because when dealing with patients with hyperacusis or recruitment, remember that recruitment is a distortion of the loudness. So the test frequency used is the one identified previously during the pitch matching. Now the masking. So you've done the pitch matching, you've done the loudness matching, and maskability is evaluated for either positive or negative effects on the tinnitus. But at that point, it's important for the professional to know what to expect with an external noise. So the results of this procedure can assist the hearing care professional in determining whether the patient is a candidate for sound generators to help control the tinnitus. So measuring the masking of tinnitus is often considered to be the most important part of the tinnitus evaluation. Noise and tones can be used during this measurement and can be done at the tinnitus pitch matching only, through the whole tone audiometry frequency range or both. The outcome of this subtest is the determination of maskability and the definition of the minimum masking level at which the tone or noise provides a masking effect. Finally, I will talk about the residual inhibition. I've mentioned that several times, and it's a very, very interesting effect which occurs only with tinnitus. It's also called as a forward masking, and it's defined as the temporary suppression and or disappearance of tinnitus following a period of masking. So you provide a masking stimulation for a while, and then the tinnitus will disappear for a while. Not for everybody, but it's important to know who could benefit of this residual inhibition. So the recommended measurement procedure is to present the masking sound used to determine maskability at a level corresponding to the mmL, we've just calculated right before, plus TDB. You also have a variation, which is the loudness match plus 10 dB. My recommendation is to use the mmL. And for 1 minute stimulation, so the patient is then asked to report the effect on their tinnitus, as well as how long it takes the tinnitus to return to previous levels. So as you can see on the screen dump, you have very easy access to conduct this test because it's integrated. You have calculated the mmL before, you just add 10 dB, you are on the pitch match frequency, and you just have to click on the play button. Then you have 1 minute stimulation for the patient, and after this 1 minute, the play button will change, and then you will have a chronometer in positive in that case, and the patient is asked to show or to tell you when the tinnitus is back. Then as soon as you click on the former play button, the result will be automatically included onto the table and expressed in seconds or minutes. Okay, now we have seen what we call the psychoacoustical components, and we'll now check the questionnaires. When we talk about the questionnaires here in this module, in this first version, we have included 3 different questionnaires. We have the THI, the TFI, and the THS. Depends on the translation available. These 3 questionnaires are basically available in English. But let's start with the Tinnitus Functional Index, the TFI, which is actually the latest one available. It's introduced in 2012, and it consists of 25 items, and it's used to determine the severity of the tinnitus as well as define the negative impacts on the patient is experiencing in response. So the question covers 8 scales that summarize the areas of intrusiveness, reduction in quality of life, emotional distress, and so on. So patients respond to the item using a 10-point scale, and an overall score that ranges from 0 to 100 is calculated automatically along the subscale scores. So it's very nice because the questionnaires is integrated and calculates automatically the results for you. Now the THI, I mentioned the THI, which means actually the Tinnitus Handicap Inventory. It has been developed in 1996 and is a frequently used questionnaire that defines a self-reported handicap to determine which patients require treatment. So it can be applied to assess outcome for various approaches. The THI questionnaire is made of 25 items. The patient's answers can help the clinician determine the most appropriate intervention and identify those patients that may be in need of further medical and/or psychological evaluation. And finally, the THS, which is the Tinnitus and Hearing Survey. So it has been developed to differentiate issues that are arising from tinnitus and those that are caused by hearing challenges. And it consists of 10 items. 4 of these relate to tinnitus-specific issues, 4 relate to common hearing problems, and the final 2 are inquiries about sound tolerance issues. Patients answers using a 5-point scale in response to a range of hearing and tinnitus challenges. Reviewing these results can be useful in counseling patients with coexisting hearing loss and tinnitus to define the boundaries of the issues. Okay, it's time for the conclusion. And just to recall that audiologists are meeting more and more tinnitus patients in their practice every day. Fortunately, there are advanced tools and solutions for tinnitus management available, from psychoacoustics measurements I talked about to targeted questionnaires. Tinnitus assessment helps clinicians to identify, quantify, and manage the tinnitus while establishing an open and constructive relationship with the patient. A tinnitus evaluation can be the first step to establishing trust with your patient. Characterizing the subjective symptoms improves communication between the clinician and the patient and provide a documented basis for treatment. A tool such as the Madsen Astera 2 is ideal for clinicians who want to help the tinnitus patient. It has a dedicated tinnitus module that enables the professional to assess the patient's tinnitus and the effect it has on daily life. Clinician makes the tinnitus assessment directly from the audiometer, and all the patient data and information is accessible from one place. Make it easier to create a treatment plan and monitor the patient's tinnitus over time. Just remember, assessment and dialogue is the key to successful tinnitus patient management. Thank you very much for attending this webinar, and but now it's time for questions.
Yes, thank you, Clement, for taking us through the benefits and the process of tinnitus assessment. We now have time for questions, and we already have some questions that have come in, but the rest of you, if you have anything, please use your menu to post more questions. So the first one, Clement, the first question we have, does insurance pay for tinnitus treatment?
That's a good question, actually. It really depends on the market, on the country, but my experience is over the world, I've seen different legislation, but most of the time the tinnitus could be covered when it's associated to another damage. For example, people who got a tinnitus, but it's basically related to the work environment, and most of the time is also associated with another hearing trouble, hearing issue. So directly it's rare that tinnitus today is taken into account, but the consequences of the tinnitus, like depression, like suicidal tendencies and others, can be of course taken into account by the legislation or the reimbursement system.
Okay. We have another one here. Can tinnitus evaluation and treatment be performed in MD's office?
In MD office?
MD.
Medical. Yeah, of course. I would say that I mentioned many times audiologists as the hearing care professionals, but I would say that it's this evaluation can be done and actually should be done as soon as possible when a patient, a patient going to the MD to complain about this tinnitus, if of course the professional has acquired the MAT and Astera 2 and has the possibility to do this evaluation, I would suggest to do it, because there's nothing really contradictory or really difficult in a way that they use this evaluation, and it gives so much information about how to manage or how to plan the management for this patient. Should he go to the features? Should he go to other psychologist support? That's the purpose of this evaluation.
Okay, and we have another one here. So briefly, how do I use the tinnitus assessment data when fitting hearing aids?
That's also a very pragmatic questions, actually, very interesting. Today it's quite difficult for us to give recommendations, because I will say that the path following the tinnitus evaluation, when you feel that, okay, this patient requires some support, and I can see that with the maskability test that it could benefit some external sound to not mask but to conduct the patient to what we call habituation of his tinnitus. And then we think about sound therapy, and then we think about maskers or the new solutions included in the new hearing instruments. Definitely, this solution can be very useful, because first the maskability will give you an idea about the good effect, but also residual inhibition will give you some ideas or will give you some pictures of how to counsel, how to give counseling to the patients. So definitely this solution is very helpful for the sound therapy, but I cannot really at this stage provide some more details about how to fit the hearing instrument based on the results. To me, and at this stage, it's more about sorting or make some categories about patients' plans to manage the tinnitus. I would say that you can, of course, use the minimum masking level to have an idea about the amount of stimulation you can provide to give a sound therapy. But we cannot really give more details about what to do with these measurements to fit the sound therapy instrumentation.
Okay, thank you. Then we have a question related to the actual software you talked a little bit about, Clement. We have a person asking, can I use it with other Matching audiometers than the Astera?
The software supporting this tinnitus module is Otosuite. For people who bought the Matching Astera a long time ago, it was very nice, because it we gave this module as an update, as a software update. It was for free and it appeared on Otosuite, and that's the real benefit of Otosuite and the PC-based solutions also we provide. Unfortunately, today the tinnitus module is only available in our Matching Astera 2 audiometer, because remember when I've mentioned the requirements to perform tinnitus evaluation in general, and I talk about the 2-channel audiometer with a 1 Hz resolution, 1 dB step resolution. All these capabilities like fresh noise, brain-bound noise, pure tone, etc., are usually provided in pretty high-end audiometers. And but basically today, this tinnitus module is only available for Matching Astera 2.
Okay, I think our time is almost up. Yes, we have actually a question coming if this webinar will be recorded, and yes, it will. It will be recorded and available, I mean, to all of you that have signed up for the course. I think you will be sent a link after the webinar where you can go back and re-listen. People that haven't signed up can go to the Otometrics website, and this is also where you can find a list of other webinars coming up in this Otometrics webinar series. But I think we will close up the session here for today. Thank you all for showing up. Again, please check out our website for other webinars. You are of course also welcome to send us emails if you have additional questions coming up after when we close up the session now. We thank you all for attending and really encourage you to fill in the feedback form that will pop up on your screen immediately after we close up here. But yes, thank you for here and have a good day.
Thank you very much.
Thanks.